So our next topic of discussion is going to be on strain, and this particular topic has about 30 slides, not much more than that. So strain and strain rate, primarily on strain and how we measure strain with the software we have on our Epic 7s. There are many applications for strain. The potential applications are there for most anything heart-wise. Where it's sort of found its home, at least with us now and other places that I've worked, is in this cardiotoxicity area, realm, if you will. And these would be serial studies on people who are receiving some sort of cardiotoxic drug that could damage the heart muscle over time. So typically they do serial studies every 3 months on people receiving any type of a drug that could damage the heart muscle to make sure there's no damage happening. That's something that strain has really found a home with, I should say. But there are other applications of it if the doctors wanted to look through the literature and actually find out just how applicable it is in different heart centers, where they're actually using it where valvular heart disease here has become a big one, and timing of the replacement of valves and whatnot. So many applications, like I say, where it's kind of found a home around here is in the cardiotoxicity realm. My sources, I just put these in here just in case you want to check them out. Mayo Clinic, DeBakey, ASC, Northwestern, that was an ASC conference. You're going to see some, if you do go into the literature at all, you see some names there that show up quite frequently, as in Miguel Iaquinos, and Roberto Lang is huge in the field, especially with the 3D realm and stuff. So these guys are typically on the ASC committees and whatnot, and research studies. A lot of research comes out of labs such as those, DeBakey, and wherever Roberto Lang is, and Mayo. So if you're just looking at EF, which is what we typically are going to give our patient an estimation of their ejection fraction, EF is by definition, it's all about the pump function of the heart. Therefore, it's going to be load dependent. In other words, the more we put in there, the greater squeeze it's going to have, the Frank-Starling mechanism, or vice versa. And the ejection fraction is not an index of myocardial fiber function, but rather it's an index of pump function, as we say here. And how you demonstrate the ejection fraction is load dependent, you should look at the ventricular pressure on this side, ventricular volume down here. If you increase the volume, that increases the stroke volume. So increased preload, which is increased volume, is going to increase the stroke volume, which shows you that it's load dependent. And that's how doctors manage fluid volumes within the heart with medications that can either increase volume or deplete volume, so to speak. So less volume, stroke volume goes down. We can see the heart has these this fiber orientation where they're arranged in this helical pattern where you get these right-handed arrangements, helical patterns, and you get these left-handed helical patterns, and they sort of crisscross over each other, inner going this way, left going this way. It's a very unique fiber orientation, and we've talked about this before, where a 15% shortening, or squeeze, if you will, where this heart just kind of wraps around itself, produces a 65% ejection fraction. So it's really impressive that it can do that with such a very small shortening cycle and pump out that much blood. And this is another picture just showing the difference between the fiber orientation where we're going this way and this crisscross, each other down in here where they really have a cutout here with the circumferential fibers and so on and so forth, longitudinal fibers. These are going to become important when we talk about our strain. And the fibers towards the outside of the heart here. Strain has been around for a long time. When I was doing my clinicals at Maine Medical Center under the tutorship of mentorship, I should say, of Dennis, I remember Dennis doing strain on a patient back then when strain was still really new. And I remember him practicing on a patient that he thought the wall was down on, a particular wall, I can't remember which one, and he actually played around with the strain package and put it on this particular wall. That's before things were automated. We had to do a lot of clicking and what have you. And I don't think it was based on speckle tracking back then. It was probably based more on tissue Doppler imaging. And that's how strain originated, through TDI. But I remember him saying he thought this wall was down. Now, sure enough, the person got calved. And I remember one of the docs there at the time, Dr. Lualdi, while reading the echo, jokingly said to Dennis that I should probably give you a portion of my read money for reading this, because the wall you did the strain on, in fact, had to be revascularized, had to be stented. So pretty cool, able to do it back then. The one and only Dennis, of course, could do that, but it's been around for a long time. But in 2015, 2016, 2017, in that area there, the EACVI, which is the European Association of Cardiovascular Imaging, and ASE, got together and developed this strain standardization task force. And they developed some standards that they wanted the strain, or manufacturers, I should say, of the different machines. And there's really a lot of them that we don't even know about. Philips is pretty popular in the New England area, GE, Toshiba, ESOTI. There's a bunch of German manufacturers and stuff like that. We really don't even. But they got a bunch of machines in there. There was a ton of, quite a few manufacturers. They put them in a lab in Leuven, Belgium, and they tested them. And what they wanted to do is they tested all these machines, and each manufacturer's, they measure strain at that point in time a little differently. Their algorithms a little different. So if you had, if you're having some sort of cancer treatment and you go to one lab and get a strain measurement, is the oncologist going to trust that measurement? If you go to another lab, you get a different measurement. And that's what would happen in the past. You get totally different measurements. So which one's correct? And they all had a number that was right or wrong too, a top number and a low number. So they had the standardization task force to get together and bring all these manufacturers and reps together to try to get everybody on the same page. So if you went from one lab to another, depending on, regardless of what machine you're using, you would have similar values when you did a strain measurement on a patient. And what they agreed on from that task force is, number one, they agreed on using global longitudinal strain for the best results. And the reason they came up with global longitudinal strain is that it seemed to have the best accuracy throughout all of the models. Remember, there's different types of strain. We're going to talk about this briefly. But this is the one we use, global longitudinal strain. Basically, longitudinal strain globally means all heart walls. This may sound kind of basic, but defining the apex and the base locations for strain was important, because some of the manufacturers put their points a little bit differently within the heart to come up with a strain value. And they agreed on using an 18 segment model. Remember, there's different models of those, 16, 17, 18. And they agreed on tracking the endocardium. And the reason they did that is because all manufacturers could indeed track the endocardium for the strain measurements. For strain, you can either track the endocardium, myocardium, pericardium. I mean, you can track anywhere in there the speckle tracking technology. So they said, well, if we're going to track and keep everybody on the same page, and we're going to track have everybody track the endocardium. That's what works best, okay? And so they look at a model like this right here, and they say, okay, where's the apex? Where's the base? So this is obviously a 3-chamber view they got here, and this would be like a 2-chamber view over here. I'm not sure why they... But when they break it down to the apical region, and they have these segments, of course, as we do in our echo models, 18 segment model we're going to use here. So we have 1, 2, 3, 4, 5, 6 segments for each apical view of the heart. And here we're going to track, over here you see we're going to track the endocardial border, but you can also track the myocardial or the pericardial border out here further out, epicardial border I should say, out this way here, right? So the strain could track either one of those, but we've agreed to track the endocardial border. And we've identified where the apex is and where the base is. However, despite these standardization efforts, using cardiac MRI as our reference standard, I'll colorize that for us. Vendors still use their own proprietary software and algorithms, resulting in still inter-vendor variability. And that was just recently published in the International Journal of Cardiovascular Imaging in 2021. And inter-vendor variability depends primarily on the software rather than the image characteristics. Okay, inter-vendor variability in strain depends on software rather than image characteristics, and the vendors are still using their own proprietary software algorithms. So there is still rather high inter-vendor variability. So the lesson learned there is to, if you are having one of these tests, or a patient of yours or a friend of yours is, have them go to the same lab or have them go somewhere where they're using the same vendor to get reasonable results, right? The EPIC 7 uses the software that used to be, it's an independent software. It uses the TomTec. Philips bought TomTec. TomTec used to be a company of its own. Philips bought TomTec and incorporated their software into their machines. And so they use the Philips speckle tracking software to develop their strain numbers. So what they found about the independent software, and there are other independent software companies too. I think EOSOT or something like EOSOTI or something like that is one of them. But with the Philips software, they found that the independent software primarily, no significant difference in scar detection capabilities in the independent softwares. That's versus the proprietary algorithms that are on the machines like GE, Toshiba, and so on and so forth. The average global longitudinal strain and I can't remember the SLS, just a single longitudinal strain values were similar. This would be, I believe, just one segment of a wall, segment longitudinal strain, I think that's what it is. And reproducibility of global longitudinal strain measurements show no difference among vendors using an independent software like TomTec, and was in acceptable range amongst those, which is really impressive. So the segmental longitudinal strain reproducibility was high, but similar for all vendors. It's been a challenge to pick up strain abnormalities within the heart. Let's go back and look at this. If you want to do global longitudinal strain on this image, what happens when you do the strain is it does a strain value on this segment, this segment, so on and so forth. It comes up with a strain value, and each individual segment adds them up, gives you a total, then divides by the number of segment, which is always 6, and that's when you get a global longitudinal strain value for that particular image of the heart, in this case April 3. However, what they're saying here is that segmental longitudinal strain reproducibility was high, but similar for all vendors. It's more challenging to get just this value, say this segment right here, and reproduce that time and time again. It's far more challenging to get just that and try to reproduce that over time than it is to get the whole segment, or all these segments as a whole globally. That's much easier to get that. There's just so much, there's so many variables introduced in just this one segment. If you add them up and spread them out, so to speak, you get a better average value. You can average the values better than you can just in this one segment, is what I'm trying to say, I guess. So it's more accurate doing the global than it is doing the single. The different types of strain. This is a global longitudinal strain, and you can see we're measuring our strain this way here in the walls. And what Philips does is it takes the length along the internal border, and we can play with that length, but it's the whole length of this right here. And you can either, if this isn't in the correct space, you can move this up and down or correct this in your strain measurements. Now, keeping in mind that your strain package now, most machines have the updated package, which is an automated strain package. We used to be able to, well, you still can. You can go in and do it the old-fashioned way and do this and manipulate the lines, and not only the length of the line from here to here, but each individual segment if you want. But if you just use the automated package, which I'd recommend you use if you're going to look for reproducibility over serial studies, you just adjust this line. If it's off a little bit, typically that's going to be in the basal area, and that'll update that, and that'll come up with these different numbers for the different areas. As you can see here, -24, -23, 20, 22, and so on and so forth in this image here. And here's our strain curves over here. We'll talk about that in just a second, because we don't show these all the time when we do these for our doctors. You can also do a radial strain, okay? And radial strain is the amount this is moving inward when the heart contracts. And this here is circumferential strain. And notice radial strain is a positive deflection, whereas global longitudinal strain is a negative deflection. And circumferential strain is, once again, a negative deflection. The machine can do any type of this strain, either or. However, we found this to be more reproducible amongst the vendors. This is just another look at the strain and the circumferential, radial, and longitudinal during diastole and systole. So let's concentrate on longitudinal strain, since that's just what our machines are measuring, and what we're trying to measure for the doctors. So we have to get our 3 apical views, and we should include at least half of our left atrium for that. We got to be careful when we get our apical with these views. There should be a less than 10% heart rate variation. Typically, I have the patient just take a small breath in, where I can see the image really well, and make sure the heart rate was, within 2 or 3 beats on each view. If it's not within 2 or 3 beats, it's potentially inaccurate, because strain and frame rate and heartbeats are very much interrelated. So a frame rate greater than 40 best, they say 40 to 70, and again, the frame rate and heart rate, there's a strong correlation there. We need to see, so in order to increase our frame rate, let's go back up here, increase our frame rate, we would decrease our sector width, bring our focus up, make sure we get a really good picture there for the doctor, make sure we get our apex in there. Need to see the ventricle and endocardium well and be on axis. We can't use contrast yet. In the future, we probably will be able to, but right now the speckle tracking technology and algorithm gets confused by contrast and can't detect the endocardial walls there. Strain doesn't like PVCs. They claim AFib's okay if the heart rate's not varying too much. In other words, if you see a steady AFib, and it's not like all over the place, then you may be able to get a reproducible strain or a strain image. However, I'd be careful if you're doing the same person. Let's say they went into AFib after you've already done it once. You'll have to do it again. And I'm going to make note right here that when we do strain on a particular patient, the first strain we get from them when they come in, say they're going to start treatment for, we see a lot of it with breast cancer. They're going to start treatment on some sort of chemotherapy. We, cardiotoxic agent, we get their baseline strain rate then and there. So that's what they're going to go with from then on. So say we get a negative 18, then that's their baseline strain. 3 months later, we'll come in, redo it, and make sure it's not changing by much. And I'll tell you a little bit about changing in a few minutes here. So longitudinal strain is basically the reverse of what you think here. So we take our length here in systolic length, we minus our original length, and we divide that after we minus that out by our original length, and we get a percent strain. Don't ask me why they've made this negative. It's kind of confusing. Well, strain is a negative number. And here you can see, excuse me for a second. The length of the line along the endocardial wall is calculated. Say this is 137 centimeters or whatever in systole, and it's 181 in diastole. So you have 137 minus 181 divided by 181 times 100%, and that's how they come up with the strain number. So again, say this is 137 in systole, 187 in diastole. 137 minus 181 divided by 181 times 100% gives you your global longitudinal strain number. I know it sounds a little confusing, but basically the length of the line along the endocardial border in systole and diastole. And we can adjust that length if we think it's not where it should be, which it should be right down in our base. We'll mention that a little bit here. So how does it track different segments? How does strain create a value? Well, when we hit the heart with ultrasound, any tissue with ultrasound, these speckle patterns are created primarily by the interference of our, as it says here, our ultrasound waves reflected from the tissue muscle structure within the heart. It's just these speckle patterns of, ultrasound speckle patterns. They call these blocks or kernels of speckles, and they can be tracked from frame to frame. And tracking these things is very much angle independent, which is good. Semi-automated, which is even better. Provide local displacement information from which strain and strain rate can be measured. And here's a picture of kind of what that looks like. See these speckle patterns in here, and you can track either one of them, but it picks two, and it basically measures them when it's in diastole and in systole, where they get they're far apart, closer together. And it does that formula I was talking about. You know, here minus this divided by this to get a percentage of the strain percentage. So strain percent, basically strain is a percent change in an object's dimension slash deformation. And this is the formula I was telling you about. LV length, we have 14 centimeters, we'll say, 18 centimeters, a particular segment we're talking about, or whatever. And using this right here, we get a negative 22%. The strain rate, on the other hand, that's how strain, the strain rate is the actual speed in which strain happens, the speed of deformation. Strain does have its advantages. Accurately IDs subclinical dysfunction before the EF declines. That's a huge advantage. Powerful predictor of cardiac mortality and morbidity for numerous cardiac conditions. Provides additional prognostic information over the ejection fraction. So it can actually be used to prognose, okay? Angle independent, quantitative, we get a number. High temporal and spatial resolution, less load dependent than EF, can assess both regional and global function, although the global number seems to be more accurate than the regional numbers, but that's neither here nor there. Can assess both systolic and diastolic function. In fact, I think in the future, strain is going to become the predominant diastolic function measurement tool, as opposed to using Doppler. Provides quantitative numerical data. It does have shortcomings. It is, depending on us, operator dependent. It's very much dependent on image quality. We can't use contrast. Artifactual interference may be misinterpreted as speckle. We got to do our best to get that true apex, especially in serial studies. Any ultrasound noise decreases its tracking ability. And again, as I mentioned in the beginning, we have vendor-specific issues on the algorithms. Strain correlates very strongly with cardiac MRI, the gold standard. It actually has a better predictor of survivability than EF, better inter-observer and inter-observer variability than ejection fraction. In other words, if people read this, readers read this, their rereads are more accurate with strain than they are with EF. Better reproducibility than EF measurements when repeated with the same software. That came out of the Leuven lab. And there is a curvilinear relationship with strain, which is a good thing, because a curvilinear relationship is the kind of relationship that happens between two variables that change as the values of the variables change, increase or decrease. So this is a curvilinear relationship. When EF changes strain, you can see here strain changes here. So it has, curvilinear relationship here. And here is a graph that's describing mortality. And we know mortality when EF occurs below 30%. It's a very high mortality rate. If you look at mortality rate up here, this is a percentage all the way up to 60%. And this is our ejection fraction of 30%, 20%, 10%, so on and so forth. Mortality rate's pretty high over a certain period of time. But over here, in this area where you're going between 35 and 60%, EF isn't as reliable. However, strain is very helpful in this area. If the strain is down, there's a very strong relationship between strain and and mortality in this area here. So it's more helpful than EF. There are normal values for strain. Phillips uses -18. Okay. Dennis uses -16, I believe it may help, as a normal cutoff, and a 20% change as abnormal. Typically that's going to be, less. And if you looked at all the vendors, and this came out of the Leuven lab, all the vendors, added them all up, took their averages and added them all up, the vendor averages would be -17. That's typically what we go with, believe it, Mercy. A -17 is the normal value. You can actually come up with basically a grading scale for strain and how it relates to the ejection fraction. And if you look at an ejection fraction as being normal, greater than 55%, then the longitudinal strain would somewhere be between -15 to -25. So there's quite a variance in there, but just the same, if you say -17, the vendor averages, that falls certainly within that. And mildly reduced, so on, moderately reduced here, severely reduced here, and this one actually is your strain. There is a relation between strain and EF, and this is basically how the algorithm works. Not sure how well that works, and I've tested it out myself, but that's there if you want to know EF and strain, how they correlate. Essentially, what you're looking for with strain is that a change greater than 15% is abnormal. And that's going to typically be a reduction in strain, say from a -18 down to a -13. A change less than 8% is typically acceptable. That's within the accepted, variability of normal, if you will, less than 8%. 8 to 12% is kind of like, okay, let's do it again. If you're the tech, do it again and make sure you've done it right. You've got all of your measurements in the correct spot and all of that. And to make sure you've done it right, just like I said, just do it twice. Do your strain twice, and so we can report that correctly. The bullseye. This is what we show our doctors. This bullseye, and this bullseye represents all the wall segments. And as you can see, the strain value over here is reduced right in this area here in this infralateral, sort of mid to apical infralateral wall area, and you can see that's exactly where it is. This you've got the outer, inner, and so on infralateral wall area right through here, right down towards the apex. Doesn't quite go down to the apex. This kind of sinks right down and around to the lateral side. You can see where the strain is down over here. These are different strain patterns that we can see in the lab. And for example, if you were to look at this pattern here, where everything is a very solid red and you've got these high negative numbers, you can see that this is a very normal heart and a very normal strain. This right here is an interesting strain pattern where this is, you're not going to see this probably this perfect in your career, but this is amyloidosis, where cardiac amyloidosis, severely reduced strain all the way around, and all the other segments except the apex is very well preserved. And this is called the strain pattern, but it's called a cherry on top. This one here, you can see this person here, strain very good over here, but you have this inferior myocardial problem going on over here, probably some sort of a heart attack, or coronary artery plugged up there on the right side. And here we have basically this here is hypertrophic obstructive cardiomyopathy, where you see this anterior septal pattern is not coming in very well, but the rest of it's coming in. So this is sort of like a hokum type thing. And this one here is pretty interesting. You take a look at that one there. Strain pattern's good all the way around, except right here, just the opposite of this one here, right? And this is what we call apical hypertrophic cardiomyopathy. So the strain is reduced right in there. And this one here is kind of an interesting one. You really can't, it has no defining characteristics perhaps, but this is a very severe AS case where the walls have weakened in certain areas. This person has aortic stenosis, and if you actually identify this person's strain pattern and did serial follow-ups on them, you could actually see if these patterns continue, whoops, I'm sorry, or change over time. Sorry about that, I moved my thing out there. We're almost done, guys. Bear with me. And here, what I wanted to show you here is these patterns, myocardial infarction down in here, hypertrophic cardiomyopathy, amyloidosis, where you see the cherry on the top here. And these are the strain lines that correspond to that. Each segment has its own strain line, and its own average line is in there somewhere, and I'll show you that in just a second. So segment number, whatever this is, segment number da-da-da-da-da-da-da, they're all right in here. These all represent, you see the colored lines here and where they, what they represent in here. And these strain patterns actually have a meaning. So this is your strain when strain happens, peak positive strain, right? We're going to come right down here, strain, 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 boom. The aortic valve closes. In systole, so this is where the strain is going negative, boom. Now it's going to come back up this way here in diastole. You're going to get this post-systolic strain curve, which they believe it's related to either, you see this peak systolic strain curve. That kind of makes sense when it, boom, starts to really contract. Then you have the strong, strong, strong contraction. Then you have the aortic valve bang, open up and close, then you start your diastolic filling period here, and that peak sort of makes sense. But what is this little bump here during diastole? They think that's either related to some sort of passive stretch and recoil when pressure drops in the LV, or perhaps it's just a little piece of the myocardium that's weak after closure. Or something like that. After the pressure lessens, this muscle's a little weak and pops back in. But you can analyze these strain curves and become pretty good at it. The doctors don't seem to be too interested in that where I'm at, but perhaps following that over a period of time in different patients with different diseases, you can actually see changes and patterns change and whatnot. This is our last slide. So this is another slide you can show the doctors if you want. I don't know if it's in the automated strain package or not, but certainly in the other package we can show the image here. We can show in the automated package, you can show your numbers if you want. There is a button for that. And you can also show this what we call this map, this M-mode map, where strain is good in this red and strain is poor in this light red area. That's another way of evaluating strain and also show the strain curves. And if you look up here in this line up here, you see this dotted line in the middle of these other lines, which represents the colors over here. That dotted line is the average of all the curves in that box. Okay, so that's it for strain. I'm sorry that to take so long. I just wanted to get that over with and done for you. And we'll move on to another, I think it's we're going to do, was it stress echo or something like that before we finish up this unit. Thank you.